My name is Abigail Johnston, and I will be your moderator today. I have a wonderful group of people here today to talk about palliative care, the things that everybody should think about, whether you have an illness or not, and the things that a lot of people don't know. I think, first off, a lot of people think that hospice and palliative care are the same thing or they're subsumed together. And I hope after this webinar, you will be able to answer a lot of these questions that a lot of people have that maybe aren't comfortable to ask. The first person I'd like to introduce is Dr. Medina. If you'd like to give a wave, Dr. Medina. She is actually my palliative doctor at the Miami Cancer Institute in Miami, Florida. And she is triple board certified, and I got that right. Yes, she just collects board certifications because she's just that awesome. And you know, there is a lot of stuff that goes into palliative care, but one of the things that I love about Dr. Medina and her staff is that they just approach things in a very gentle, in a very inclusive, and in a whole person type of way, which actually probably defines palliative care pretty well. So she's here today to speak from her experience and her board certifications. She did do a lot of her education down here in South Florida. And certainly if anybody's interested in learning more about her triple board certification, you can look her up on the Miami Cancer Institute's website. The second person on our all-star panel today is Marianne. Would you like to give a wave? And she's a breast cancer survivor with a particular interest in palliative care. Her project, I'm actually forgetting what the project's called. Marianne, have you named the project? Is it Palliative Care for All?
Yes? No, we are not using that name, but we're still working on that.
Okay, but the whole idea is, when is palliative care available? Why is it available? And who is it available to? Marianne is really working hard on gathering information on that and wanting to make sure that everyone who wants to have access to palliative care has access to palliative care, as well as identifying those places that have an exemplary program that can then educate other programs on how to have an exemplary palliative care program. She's also really good at connections. So if any of you guys listening need a speaker for anything, Marianne is a really good person to talk to. And like really big organizations like Komen come to Marianne and ask her for suggestions. So anyway, Marianne, you're gonna get a flood of requests now. So
that's fine, I'm here.
There you go. The third person to round out our panel today is Jennifer O'Brien, who is a new friend who Marianne introduced me to. Thank you for waving, Jennifer. And she is the author of the book, The Hospice Doctor's Widow, and it's available on Amazon. And that was written based on her journal that she kept during the time that her husband was in hospice. I was amazed by her book. I think that it is a must read for anybody, but especially caregivers who are looking at what does the hospice experience look like from a caregiver's perspective. And man, she keeps it real. She talks about how her husband wasn't always her favorite person during the hospice the process of being in hospice, and that tells you she keeps it real. So it's an amazing resource for families, for caregivers, and quite frankly, she's just a really amazing human being. So thank you all for being here and giving of your valuable time. So I'd like to start with Dr. Medina to just give us a basic definition of what is palliative care.
That's an excellent question, Abigail. Perhaps it's probably the most important question that people actually want to know for this evening. And quite frankly, palliative care has a very long, extensive definition. And in order to do justice to all the work that we do, I took the time to write down a little paragraph about exactly what it is that it means, as there happens to be still many misconceptions between hospice and palliative care. Certainly the WHO definition is very long, as well as the CAPC definition, which stands for the Center to Advance Palliative Care. So I took the liberty to write down my own definition, which is still a little bit lengthy, but I figured if we know exactly what this means, we will really be able to really assist people in really wanting to know what this is. So just bear with me a few minutes. So essentially, palliative care is a specialized medical care for people living with serious illnesses. This type of care or approach is focused on providing relief from symptoms and stress during the course of a serious illness. The goal is to ultimately improve quality of life for both our patients and our families. Palliative care is appropriate at any age or any stage in the course of a very serious illness. It can be provided along with all appropriate treatments and services, okay? Palliative care is also provided by a specialty trained team that includes doctors, nurses, or wonderful chaplains and social workers and other specialists as well. And we work collectively with other doctors or the other treating clinicians, as well as the families and caregivers to provide that extra layer of support that our patients often need. So specialist palliative care is provided really in partnership with the family, the treating clinicians, and is delivered concurrently with disease-modifying treatments. Our team addresses all the medical, psychological, spiritual, and social needs of complex, seriously ill patients and the families. The team also helps to communicate with patients and families about goal setting, priorities, what to expect in the future, and we also assist the families in complex decision making and exploration of really medical treatment options. We also assist our patients in communicating all of these wishes to their family members as well as to other treatment providers. So that's in a nutshell, but very lengthy, what palliative care means.
Well, that is a very rich definition of what palliative care is, and thank you for giving us that rich definition. When you talk about is for seriously ill people,
right.
Can you expand on that just a little bit? Because I think that there may be a perception that you have to be terminal to be eligible for palliative. Could you expand on that a little bit?
Sure, that's a wonderful question. So any serious illness can include any conditions such as cancer, neurological conditions like Parkinson's, ALS, any end organ condition like heart failure, COPD, kidney disease, etc. You know, these are oftentimes conditions that are protracted, they're long, you know, and patients been having indeterminate prognosis when they have these very chronic, prolonged medical conditions. And quite frankly, some of these patients may not be eligible for hospice because they don't have that qualifying, you know, a certification of 6 months or less. But in fact, these are the patients that are really the most appropriate for a palliative care approach on, you know, by an interdisciplinary team. And so it does really encompass a lot of our very serious illnesses like cancer and the ones that I mentioned above.
Okay.
Hey,
so
Abigail, can I jump in there? Is that okay?
Yes.
Jump in, please. Absolutely.
All right. I just would love to give the patient perspective on what is palliative care. And the newer term that's being used is supportive care. So if you, at your facility, if you see supportive care and you don't see palliative care, that's okay. And it's probably more common to see that. But from a patient perspective, I define supportive care as the ultimate in personalized medicine because it's all about you. There is no cookie cutter approach. It is quality of life, but it's quality of life as defined by you. And that definition can change as you move through your cancer experience. And so that to me is why it's the ultimate in personalized medicine that truly is delivered. And as what you were heard, it's in conjunction with your treatment. It's not in replace of, it's not instead of, it's added to. So we'd love to say that it's an extra layer that you are getting of care. And it's not just you, it's your family as well. So that is just a powerhouse of care that you could be getting from supportive care. And the other thing I want to mention is there are so many studies that have been done over the years that show if you give a patient supportive care early on, as early as even as diagnosis, you not only can, you know, obviously increase their quality of life, but you can increase the efficacy of the treatments they receive.
Absolutely.
And sometimes you can even extend that patient's life. So that's just a powerful tool. And that's why bringing it in at the end of life, you have missed such an opportunity for really, truly helping that patient and the family.
Marianne, you ask a lot of great questions, if I can jump in as well, because I talk a lot about integrative care, right? And how we've changed the definition from alternative, right? Alternative is in replace of or something else, but this integrative care approach. And so I'm wondering if the supportive care or palliative care would also fall under that umbrella of integrative care.
I haven't quite really defined it that way, but I would like to call it like more comprehensive, all-inclusive. As Marianne mentioned before, and it's really tailored to that particular patient. It's very individualized, and it's going to be very different for that particular patient and a family as opposed to other patients. But I guess it could be considered, integrative, if you will. That would be another way to probably describe it. Why not?
I think that one of the things that supportive care tends to offer is also care management, which integrative care doesn't necessarily offer, even though they have many of the components that a supportive care team would offer you. And at the end of the day, if you're not getting the care management, but you're getting those pieces from integrative care, that's fabulous, because that's better than nothing, right?
So in my book, it's an art journal, and so there's a lot of pictures, and my description of palliative care is an umbrella. So when you get a big diagnosis, when somebody in your circle gets a big diagnosis, doesn't have to be a terminal diagnosis. In fact, a few years ago, Tony Roma, the quarterback for the Dallas Cowboys, was prescribed palliative care because of a bad injury that was affecting his identity as a quarterback, right? And because palliative care, so when you get a big diagnosis, a steady rain starts on you and your circle. And so I chose to depict it as an umbrella. So if you imagined that you were under that umbrella and you looked up, and each of the sections of that umbrella is a section of palliative care. So it might be pain management, symptom management, social services, chaplaincy, and these are all the chaplain and the social worker, and of course the physician and the advanced practice nurse. And every once in a while, there's also a clinical pharmacist involved, because you're getting a lot of medications, and that person is sort of tracking, hey, this might be causing that, and this might be causing that. And so you're getting this team approach, and you have the option for all those things, but you don't have to access all of those things. It's kind of a little bit, and sometimes all of those components and team members are helping you sort of from the background, right? They're meeting in the morning together, talking about the patients in the scenario. Sometimes when the social worker had a few minutes with you, he or she picked up on this thing. And so it's a really incredible collaboration. It's my other background, my Make a Living background, has been in teaching physicians the business and leadership side of medicine. So I can tell you I've worked with a lot of specialists, and it is the one specialty where I can tell you in no uncertain terms the physician sees him or herself as part of a team, not de facto the leader of the team, right, but as very much a collaborator on that team. And so anyway, and that, you know, so that's how I sort of, and then you look up and you have that umbrella, and sometimes the rain lightens up and you don't need palliative care for a time. And sometimes it gets heavy or the wind picks up and you need a little more help. And then and the other thing that palliative care very much recognizes, which again, not all specialties do, is the fact that at the end of life comes death.
Right.
Fact. And so palliative care it keeps that in mind, that this doesn't go on forever. And we want to make it as full and as positive as it can possibly be. And we want to be realistic about who you are and what your wishes are. And so palliative care can very easily transition the patient and the family to a hospice status. So hospice is actually probably one of those sections of the umbrella, right? Mm. Do I kind of have that right?
Yes, absolutely.
Thanks.
I love that metaphor.
That metaphor that you provided.
Yes,
it's perfect.
That metaphor is just lovely for the I think the intention and the idea of what palliative care is designed to be. But I know that one thing we talk about a lot in the metastatic groups is how does a patient learn about palliative care? And I know I had asked Dr. Medina for some statistics not too long ago about how do people find her. So would you like to share about where patients come from when they get to you, Dr. Medina?
Sure. In my particular situation, it's very easy to access palliative care because I work in a cancer center and our clinic is literally embedded in an oncology clinic. And so that really makes it very simple for our patient population. The only downside to that is that unfortunately, I don't really get to see too many other patients outside of the oncology environment. And I'm not able to see as many patients from the community, just basically the patients from the cancer center. But essentially, it's been a very collaborative effort, and so that way the patients can actually access me very quickly. I suppose for patients who live in the community who are routinely seeing their primary care doctors or their specialist doctor, they can always ask that provider, about palliative care, about those services. That would be one initiative. There's also a wonderful resource in the community. I think it's called getpalliativecare.org, where there may, and there's like a very nice cheat sheet, if you will, with many frequently asked questions, and there's also a directory. And perhaps they may be able to find physicians in the community or teams that they may be able to consult and to see. If patients are hospitalized, it's also very easy because we have a lot of support and a lot of services in the hospital. And so essentially a patient would just have to ask a doctor or a nurse if they can see a palliative care team, if that service is available in that particular institution.
And Marianne, from a patient perspective, what are you hearing from patients as to how they find out about palliative care?
They say, "What's that?"
I get that question all the time.
They've never heard of it, and they've never had their clinician initiate a conversation about it. So I think among all the stakeholders that supportive care touches, there is a huge gap in understanding that A, it exists, and B, what does it do? What are the benefits of it? And when do you bring it in? So that is part of the reason why patients are not getting the access to supportive care like they should be, even though we know about these studies that prove how effective they are in changing the experience. I think that the patients have to be, that self-advocate and be looking for information as they would on their disease and on their treatments that they're being told about. Explore what is out there at your center. And you're going to have to look for more than just the term palliative care or more than the term supportive care, because there is this language barrier that confuses it even more. It's called so many different things. And really what you're going to be looking for is a department that sounds like the definition you just heard today. And I don't care what they're calling it. That's the department that you should be calling directly and saying, I want your services. How do I get them? And find out.
Or having that discussion with the doctor that you see the most. If that's your medical oncologist, your primary care doctor, are those doctors also people who know about palliative care in your experience, Marianne?
Yes and no. Some of them know about it. However, the reason I even began to look into creating an advocacy initiative is because in the breast cancer peer support group I run, we had a metastatic member who told us that she was able to finally get approved for supportive care. And should we celebrate with her? Because look how great this is, because her oncology team told her she wasn't bad enough yet to get it. Exactly. And that was my first big clunk on my head, oh, wait a minute. Is this a thing, or is this happened to be just an oncology team that wasn't, educated on this service? And it's a thing. And metastatic breast cancer patients, just by diagnosis alone, have more than their fair share, right? And we need to do everything we can. And this exists. So it's not even that we have to create this service. These services exist. So let's get them the access that they deserve to have. And that's why I say, if there is a department at your cancer center that offers services like this, go to that department first. Ask them, what is the protocol for getting your services? And then you can also pull in your oncology team and say, hey, this is what I did yesterday. I talked with Dr. So-and-so in the supportive care department, and this is what they told me to do. And so I'm going to be pulling them in. That's where I say, be that self-advocate and get what you need for it. Sometimes people are told, oh, also you need a referral, and I'm not going to give you the referral because you're not bad enough yet. You don't always need a referral. And so I would say sometimes the oncology teams don't understand all the details. They don't know when to bring it in. They don't understand that referrals are not always necessary, right? There's a lot of misinformation. So, but we can help with that. We can help, people understand what the reality is. So let's get the care that the metastatic breast cancer patients deserve to them as early as possible.
My experience with part of this problem, again, looking at it from the specialist standpoint, the primary specialist standpoint, is the misconception falls under one of two headings. They don't truly understand. They use palliative care and hospice synonymously, and so they say, oh, you're not sick enough for that yet. I mean, it's a real issue among physicians of all shapes and sizes. The second issue that's very real, I think, is that the oncologists say, or the neurologist or whomever it is, has in their head that they do this, that they're providing everything you could possibly need that palliative care provides. And those are the two big stumbling blocks. And Marianne, I think your suggestion is awesome, to advocate for yourself, seek out whether it's there or not before you broach it with your specialist, with your primary specialist, because I think that would be very, the relationship between the oncologist and the patient is such an important one, and it's so close. And if you had one of those oncologists who really thought that they were covering all that, or thought that palliative care was the equivalent of hospice, and you said, hey, I want this thing, and they said, oh, no, that's not for you, and then you went and did the research afterward, right? Then it would be harder to reapproach. But if you sort of do some background checking before, I think you've got the order exactly right, Marianne.
I'm glad you think so. I don't want a patient to be in a situation where they're asking anyone on their medical team for something to help them with like supportive care, and they're being told no, and they go, oh, okay. And they leave it alone, and they never get the supportive care that they deserve.
Right, because it is so much more than any oncologist can really provide. I mean, they have in their head that they're doing it, but they just don't understand the full range of services and team approach and interdisciplinary approach that it is.
Yes, and I was incredibly blessed that in one of my very first meetings with my medical oncologist, she sent me right over to Dr. Medina, because I do think there are those doctors who really do get, here's my lane, I'm going to focus on killing the cancer, because that's what medical oncologists do, right?
Exactly.
All those other things that come because they know they come, other people do that. Other people have that specialty. And I think that that's where, if you are in a cancer center where the medical oncologists understand that, you don't have to take some of these extra steps. But I appreciate the explanation of, this is what you can do if something like that happens. And I do know that there are several large cancer centers where they don't look at palliative care as being something that metastatic breast cancer patients are able to access if they are no evidence of disease. So once they get to that plateau where, some people call it remission, it's not really remission, but where the cancer is behaving itself to the point where you can't see it in the body, that means that they are ineligible for palliative care. Now that is an internal type of regulation that doesn't comply with the definition that we know about palliative care. And I am very thankful that at MCI down here in Miami, that is not an issue.
There are still many clinicians in our institution who might not still understand exactly what palliative care is. But one of the strategies that we have used in order to obtain referrals has been using the word symptom management as a way in. And I think they have really, really bought into that. And at least from a symptom perspective, when they see that patients are really struggling and are really in distress, although they may not entirely understand what palliative care means, they can recognize that their patients do need help, and they do initiate those referrals. And so I haven't really encountered any doctors really in our facility that have told the patient, I don't think it's time, I don't think you meet criteria to go there. I think it's been the other way around, but I think that concept of, I have, colleagues that I work with that could really help with symptom burden, with the stress has really made a difference in the referrals that we get. And I quite frankly get many referrals every single day, and it has been a way as using symptom management as the way in. They almost never really use the word palliative because it gets confusing. They might not use the appropriate terminology, but they can often recognize that there's distress and they actually do send the patients and do refer them.
So there we go. We've got supportive care, we've got palliative care, now we've got symptom management. All right, so we're building our lexicon here.
There's quite a bit, and that's why I say don't get caught up in the term, whatever that department is called. Make sure you understand what the services are, and that's what you're going to go after. But I think it's important also for the metastatic community to know that for several years now, ASCO has had guidelines in place that mandate that supportive care be given early on to all advanced cancer patients.
Correct.
So you are not out of line to be asking for as soon as you get a diagnosis. You are right in there with what ASCO is mandating. It's just the guidelines are not being followed. So let's help them. Let's help our clinicians, get on board.
Would you define ASCO for our listeners, just in case they don't know what that acronym is? It's the American Society of Clinical Oncologists, right?
Yes, I'm sorry. Yes.
No, that's okay. That was one of the first things that I struggled with when I was newly diagnosed metastatic, is there are all these terms and there's all these acronyms. So I try to remember that. Jen, would you share with everybody how long your husband spent in palliative care?
Well, so the irony, of course, of my situation is that my late husband was a palliative care and hospice doctor and was diagnosed with a metastatic stage 4 cancer, not breast, but a cancer, and lived for 22 months from diagnosis. But the irony, of course, and for me was that our palliative care was DIY. And so all of those things that we talked about that under the umbrella that help the caregiver and the circle and the family, I didn't get that. I knew it existed, lucky me, but Bob was really determined, and Bob was determined to, not be the patient of his partners and his fellows. And I was determined to support him in whatever he wanted for the end of life. So, or for what he had left of life. So I just figured some stuff out, and I had also lost I lost my brother at a very young age, and I lost my mother to pancreatic cancer. So I had, some personal experience, and I kept the art journal purely as a self-care method, just needed to get my thoughts and feelings, and because I was incorporating a lot of what he used to share with patients and families, we were now turning that on ourselves, and I created collages about that, because I don't know, because that's what was in my head and heart. So anyway, that was sort of our story. And did I answer your question?
Yes, absolutely. I think the point that I wanted you to make, which you made beautifully, is that palliative care is all about what the patient wants. And if that means you're not going to an official or organized team, that doesn't mean that you're not actually benefiting from this concept. Yeah. But Dr. Medina, how long if you have a typical length of time, how long do patients tend to receive palliative care?
That can be very variable. It really also it's determined by the time that the patient is referred to a team. And so in my experience, for example, I may receive patients that are, quite frankly, very, very late referrals, probably within days or weeks of death, which is quite unfortunate because I feel that there's not a lot that we could intervene. We could have intervened a lot earlier. But in the ideal case scenario, we would really like to see, especially those stage 4 patients, to be seen on onset of diagnosis. Perhaps there may be a very heavy symptom burden at that time. There are times when there is, but there's also a huge psychological impact lots of stress around that diagnosis and really coping and internalizing all of that information. So ideally, if it were up to me, patients would get palliative care from disease onset all the way to death and the bereavement period in the hospice transition.
So what you were saying, Dr. Medina, reminded me that another supportive care doctor taught me that supportive care is all about trust.
Right,
And
absolutely.
building trust between that patient, the family, and the supportive care team. And can you imagine trying to build that level of trust at the end of life when you're in the crisis? Right? That's going to be extremely difficult. And the supportive teams do everything they can. They do the best that they can to offer the services. However, if you brought them in early on into your care, and we're able to develop that communication and that trust among all the members of your team and you, now you have them. And when you're thinking the most clearly and when everything is the most calm and stable that it's going to be,
correct,
on your side. And when things start going a little, wonky, then that's okay, because now you're going to feel good that you already have this team who knows you and what care and treatment that you want.
Absolutely.
So, yeah, I thought that was so interesting, to learn and think about that and connect those dots. And he said to me, well, we're the doctors who listen. I don't know how the other clinicians would feel about that, but that's how he described it.
But that's such a good point. And if some of you heard the webinar 2 weeks ago about estate planning, that was the exact same thing that Anna Spencer shared with all of us, that you do your estate planning before the crisis. You do it while you're thinking clearly, while you have the space to think through things. You don't do it when there's a crisis. You don't do it when everything is in chaos or when you're overwhelmed by symptoms and cannot even communicate clearly what you need. So it's an excellent point about seeking something like this early. But Dr. Medina, what do you say to patients who say, why do I need to add another doctor? I've already got 5 doctors that I have to see all the time. What do you say to those patients? They may not say that to your face, I guess.
I do get that question all the time. It's a complicated question to answer, and it's very hard to convince them why they need you. Oh geez, what do I tell them? One of the things that I really want to make sure that I do at the beginning, like you mentioned earlier, is to engender that trust. And I always communicate to my patients that we are in fact part of their oncology team, because they often feel that we're outsiders, we don't know any better, we don't know who they are, we've never read their chart, and that's not quite necessarily true. By the time I actually see a patient, I've pretty much dissected the chart from head to toe. So I know as much as the oncology does at that point. And so I really make sure that they understand that we're all part of the team. And I really tell them, look, your doctor is genuinely very concerned about the quality of your life, the way that you're tolerating your treatments, the complications that we've had so far. And, we're offering you an opportunity to do better with your symptoms. We want your pain to be better. We want you to have more psychosocial support. And we actually want to help improve your function and your ability to continue to receive the treatments that you still desire, because often that is the goal. Patients do want to get better. And so you really help them understand that you're really there to support them 100% of the way. And it doesn't really matter which direction they take, whether they really want all maximal aggressive treatments, that it's what the patient and the families want. And you are supportive no matter what. I mean, you still make good, sound-based and evidence-based recommendations regardless, and you guide them to really make that best decision. But ultimately, you're there in their support, whatever the case may be. I don't know if I went off on a tangent or answered something else.
No, you're fine. I know for me, I have a lot of doctors, and so that's always just a thought process. Right. What have you heard that, Marianne, from people that they just don't want to see just one more doctor, have to make one more appointment?
Oh, I'm stage 1 and I felt that way. So I get it. Yes, absolutely. I think that one of the benefits that a true supportive care department will bring to a patient is that care management and lifting the burden of you having to navigate everything on your own. Right. And so that would be the reason, if anything, you should try it and see. I mean, what's the harm in trying it? And then if you don't like it, don't use it. You know, if it's not for you, it's not for you. But I'm gonna say, I'm hedging my bets that you're gonna like it. You know, you're gonna like someone setting up appointments for you on your behalf, and it's gonna support your family as well. And wouldn't that help you, the patient, feel better?
It's so helpful to have a group of experienced people who have been listening along the line, observing the patient and the people closest to them, so that when things get tougher, when things get more emotional, you have this objectivity to remind you what your target, what your goals of care were, what you were aiming. Not that you can't change your mind. You can, of course, change your mind, but like a rudder, you know, like a rudder for the trip, to come back to, okay, this is what we had talked about. Are we still there? That sort of thing. And just because, you know, I can't even impart on you how, I mean, Bob and I were very well versed, right, in all of this, and it still was, it was immense. It was you know, it was huge as it started to, you know, as he got closer to death. We were very lucky because we had planned and approached for the whole thing, so that all I really had to do was, you know, love him and miss him, but that was still huge.
The fact that medical school curriculum is so curative focused is part of how we got to where we are today. You know, so if the clinician doesn't consider supportive care or doesn't know about it, sometimes it might be going all the way back to their medical school training because they never heard about it. And so they're focused on either curing you, or in this case in metastatic, prolonging your life as long as possible with treatments, right? And it sounds to me, from what I've been hearing, Dr. Medina, you can correct me, that supportive care doctors tend to be the ones trained in having those tough conversations with patients and families. And oncologists sometimes even refer those conversations to a supportive care doctor, you know, and so it's coming back to the patient and saying, you know, 5 months ago when you were diagnosed, this is what we discussed as your quality of life and your goals. And now I want you to understand what the treatment options you're being offered are and how they relate to those goals. And are you still on board with those goals, or should we reassess that? Because sometimes connecting those dots, you know, when you have so much going on as a patient, is really tough. And understanding what the doctor's asking me to choose, you know, between the IV chemo and I don't know what to do, that supportive care team is going to help you understand, what does that really mean to your life and your reality.
Certainly, Marianne, and I can even tell you my own experience. I did not know what palliative care was as a medical student. I don't believe that I saw it anywhere in my medical school curriculum. I learned about geriatrics and palliative care when I became a resident. Fortunately, I was able, you know, to rotate with a wonderful palliative medicine specialist, which not all hospitals have, you know, that opportunity to work with a specialist like that. But I had never heard of it before. And you're absolutely right. With the, you know, some of the staff in our medical oncology service were not trained in communications training, in how to have those difficult conversations. You know, they were not really taught to like partner and advocate for those family members. That wasn't part of their training. Now there's a newer school of younger oncologists that are coming in that are probably training in places like MSK and MD Anderson, where they have, you know, very robust teams, and they are getting this education and this training before they even complete their oncology fellowship. And so it really depends. I believe it's probably a generational, you know, situation, but you see a mix of both. And you're right, in the event that maybe a medical oncologist does not feel prepared or comfortable having that conversation, they do rely on us quite a bit, you know, to help them, you know, with those conversations. What are the next best treatment options based on what your goals and priorities?
Mm-hmm. You know, it's interesting also, I had supportive care doctors tell me, we have no horse in this race. We are here completely for the patient and the family. And a lot of times the oncology team is very focused on that win. You know, we're going to get you another year. We're going to get you that extra 6 months. But is that what the
fight?
The fight, whatever you want to term it as, right? But does that really in line with what the patient's goals are?
Yeah, often it doesn't. It doesn't really align with those types of goals.
We keep talking about these goals, and we keep talking about coming back to the goals. So Dr. Medina, would you talk a little bit about how do you guide patients to set their goals?
You know, in terms of having a full goals of care conversation, I mean, I can tell you this is something that I do on the initial intake and the initial consult. You know, what's most important to me is to really build that rapport and that trust on the very first visit. We may not have time to really discuss everything because there's really a lot to cover. And so I really tend to focus on the priorities during that visit from a patient's perspective and really helping to build that rapport and that trust from day one. Now, goals can be very variable depending on what part of the trajectory the patient is in. You know, for example, maybe at diagnosis, maybe patients, for example, who are lung cancer stage, I don't know, 3A, for example, maybe their goal at that time may be curative. I really want to try all curative treatments to really beat or treat or eradicate my condition. You know, as patients, you know, continue their journey, they have their chemotherapies or their immunotherapies or their treatments. You know, if they don't respond, then goals might shift and change a little bit. You know, maybe your goals might become, I want to live another year to make it to my son's graduation, for example. You know, it really depends on the trajectory of the illness, the response to treatments, and where we are. You know, for some patients toward the end of their life, their goals, you know, may be primarily to spend time with their family members, to be able to eat ice cream, not to experience pain. Not to experience any distress. And so the goals can be very variable depending where patients are. But, you know, whenever possible, I do, you know, try to have those conversations as soon as possible, as early as possible, if you will.
While the patients are still with it enough to be able to really articulate those things.
Participate and I'm able to elicit from them, not the family, what's really important to them.
And
do you
Dr.
find,
Medina, aren't you the one that tends to have the conversation of it's time to transition you into hospice? It's time to, right?
I find myself doing it quite frequently. There are some oncology colleagues of mine who are very comfortable doing that. Others are not. And for those that are comfortable, they had a challenging situation or a challenging dynamic with a family member, they might really request a little extra help from us to get them there. But, you know, there are times when both teams do it. There are times when I pretty much almost exclusively do it. I have been able to identify which are my colleagues that I think have a harder time, you know, making that transition. You know, it's equally challenging for them as well. And so I kind of know based on who's the referring provider what it is that I need to do, because I've kind of learned their style and know what they're capable of doing and what they're not at this point.
Knowing yourself is the best first thing, right? And then knowing your colleagues.
Right.
Do you find that some of these discussions are very different based on the age of the patient? And do you find that some of those goals or some of those discussions tend to be very different based on their age?
They can be, and it's also, I think it's a generation issue. I think it's also a cultural issue. You know, Miami is a very, you know, diverse community, but there's a fairly large amount of a Latin community here. And there may be some misconceptions in the community where, you know, some adult children may not want their parents to know that they have cancer. They may not want their parents to know the extent of their cancer because they're constantly worried about, you know, removing hope from the equation. And you know, I know there are ways to have those meaningful, fruitful conversations without removing hope, because I always try to focus on what we can still do even if things are not going well. To me, that's extremely important, because if you lose that trust and that hope, you have nothing. You have no relationship.
You know the patient, you know the family, you've developed that trust, and then you approach those discussions in the best possible way for that particular family, which you don't have in many other places in oncology. But Jen, I wanted you to talk a little bit more about the caregiver support, whether you received it or not. And I'm sorry that it sounds like you didn't receive as much of the support that you could have, but oh, no, I understand. But a lot of what we know in the metastatic community is that our caregivers don't get a lot of support. And for a lot of us who have husbands who might not seek out support groups, or who might not seek out what you would call traditional support, there is still that worry that we have these people in our lives that, you know, we can see that as much as it's hard on us, it's hard on them. So would you speak a little bit more to that as a caregiver, having gone through this process?
The classic sort of plight of the caregiver is that you are working very hard to provide comfort for the person you love. You are exhausted all the time. And when it lets up, it's because you lost the person you love. There is support for family caregivers. There is an increase in awareness of the needs of family caregivers finally. But yeah, it's a huge problem, and understandably, you know, the main focus is going toward the person who has the cancer because they have the cancer, and we want them to feel comfortable. Every specialist I've ever worked with, neurologist, oncologist, acknowledges there is a big gap between the care that they can provide for the patient and what the caregiver needs to help them feel supported and take care of the patient. There's just a huge gap in there. You know, it's one of the reasons that my very private diary became a book instead of staying my journal about the saddest time in my life and whatever. I'll go through that someday, some therapy for that someday. There are, as of May, there were 53 million caregivers, up 9 million from 5 years ago. Family caregivers in the United States, caregivers who live with their care recipient are spending 37.4 hours a week caregiving. So they have a second full-time job taking care of the person they love. The average age is 49, so this is not strictly an old folks deal. About 25% of caregivers are millennials. And the average duration is 4.5 years. And at the end of that 4.5 years, we lose the one that we love, that we've been taking care of. And so it is the hardest job you'll ever do. I have done some very difficult things in my life and my career. I have never done anything as hard as taking care of my beloved Bob. And it's the most, you know, it was the greatest honor.
This is an amazing honor that I'm carrying this burden, because at some point it is a burden. So I appreciate you sharing that. I did look up, it is caregiver.org that she was referencing. Did you, Jen, ever have the opportunity to just get away and be by yourself? Or was that not something that was part of yourself? Okay, good.
Certainly, you know, Bob was, the most important thing to Bob was to work. He wanted to continue to take care of patients. So he did that. I did a lot of managing of our, you know, we downsized, we moved out of our big old house and we moved into a condominium. We, you know, rewrote lots of documents. We put things in my name. I did a lot of administrative sort of support stuff. And then about 6 months before he died, he could no longer work. And that was when the sort of intense caregiving started. And but he was always up until, I don't know, the last well, I would say the last 3 or 4 weeks, I mean, I could leave him alone for if I wanted to go have coffee with a friend. The last few weeks were hard because I didn't feel comfortable leaving him alone. And he really, I mean, we had a couple of times where friends came over and sat with him while I went and did something, but he really, you know, he didn't want anybody but me. And in fact, in the when he was in hospice status, we had a bad night one night, and I called the hospice nurse. I called in to sort of say, hey, this is what's happened. And by the way, you can do DIY palliative care when the patient is a palliative care doctor. There's no such thing as DIY hospice, okay? So don't even try it, my friends.
Good point. Thank you for making that point.
Take it from me. But anyway, at one point I called in and was describing what had happened, and this was a hospice nurse, and she knew Bob, and she and we live in a small town. I'm in Little Rock, Arkansas. She says, "Are you there alone?" Yeah. Well, can y'all not afford help?
Oh.
And I said, well, we can afford it. He doesn't want it. And she said, Jennifer, I've been a hospice nurse for 10 years, and I could not do for my husband what you are doing for him right now. And so that was really validating that, you know, especially for a non-clinical person like me, which I am, but it was very validating.
I also heard from what you said, don't be afraid to ask for help. If you're
Yeah.
caregiving and it's getting difficult, that there are those things out there, even if it's not you have to pay for private care, but there are programs out there.
There is a lot of help. And the other thing, yes, that's exactly right. Absolutely ask for help. And I don't mean to say that there were many things in my situation that were extremely helpful that a lot of other people don't have. You know, we had access. Bob had been a physician in this community forever. So there were doctors falling all over themselves to help him. So we had a lot of things that we were very fortunate for. I had a lot of different kinds of support that lots of folks don't have. So absolutely, my advice is, I'm actually going to put out a downloadable thing with some, what I'm going to call sort of free or very low expensive self-care for the caregiver. One of the things that really bothers me about what's happened with this notion of self-care for caregivers is, sort of a shaming thing, well, you need to take care of yourself. And you can practically hear the finger wagging, and it's like, I don't need that extra layer of pressure or directive, right? Sometimes the greatest self-care I can get in a day is 4 consecutive deep breaths. I mean, I'm not joking. So I'm trying to put together a list of sort of things like, very simple things like, being as easy and kind to yourself in your thoughts as you are to a friend. I am so much harder on myself than I would never speak to a friend the way that I talk to myself in my head. And things like at the end, instead of doing one day at a time, looking ahead at the day, do it in the evening. I got through another day, right? It makes a huge difference. Some days, one day at a time seems insurmountable. A day is insurmountable. I'm lucky to get through the next minute and a half. So yeah, I'm actually putting together some stuff because this is National Caregivers Month. I'm gonna do something where I have it on my website. You can download it. Just a little, 10 tips. And I think I might include the caregiver rights. That National Alliance has 10 caregiver rights that I've been posting on my Instagram this month. And it's so funny to read them myself then, right? And go, hey, yeah, that's right. I could have really used this in a certain moment back in the day. So anyway, yeah, I'm gonna put something together on that.
That conversation was Beautiful. Oh my goodness. Yeah. So it's based on what, Jen, you were talking about. And Dr. Medina, would you say that what caregivers go through as they care for their loved one through metastatic breast cancer could be considered PTSD at the end of the day? Like, could they pick up a traumatic stress disorder because of it?
I would probably say there's a possibility that that can actually happen. You know, I am not the expert in diagnosing PTSD, but certainly you know, and just as you're mentioning that, I'm coming across, you know, some patient examples where definitely that could have been a situation where a caregiver was, you know, acquiring these types of behavior concerning for PTSD. I think certainly it's a possibility.
Because, you know, as breast cancer patients, you know, I say the diagnosis is traumatic, right? But when we cancer, our loved ones cancer with us. And so it's got to be traumatic on some level for them. So that I'm just connecting with what Jen said, that when she was done, you know, even though you're tired all the time, then your loved one is gone. So
Right.
then what's happening to the caregiver?
Well, what, you know, it's a great question, Marianne. I think the greatest risk for trauma is, I mean, I think there are plenty of opportunities for trauma for the caregiver throughout the caregiving process, because even, you know, Bob had his moments. He was a surgeon before he was a palliative care doctor, so he could cut you down at the knees without even thinking about it. He could bring you to tears. It was part of the training.
Right.
So when he didn't feel well, right, that would happen sometimes. I mean, I didn't cry. Okay, let's just get that straight. But he could get a little bit ugly at times. So there's plenty of opportunities for trauma, but he was, you know, he was by and large very civil to me. I read, there's an excellent book. It's called The Caregiving Wife's Handbook, and it is very much written for a wife. And I know we have wives that are caregivers for metastatic breast cancer, but I also think it's worth a read. It's a wonderful book. Diana Denholm is the author. Anyway, I'm going to just come back to where I really think there is the greatest risk for trauma for the caregiver and the family is as you get close to end of life. Because we remember the days our children were born and our grandchildren were born, and we remember the days we lost the people we love, and we remember the days leading up to losing the people we love. And if we haven't had some conversations, and this is where palliative care is just so incredibly valuable, right? And if we haven't had some people to remind me as the caregiver that no, this is what he wanted, right? It's not this is not your death. This is, I mean, you don't say that, but you know, reminding them that yes, we're on track for this person's goals. Right. You are giving them exactly what they asked for in being supportive, whether you're doing every possible life extending measure or you're doing none of them, right? You are giving this person exactly what because we talked about this, and then I can feel like, yes, I was a part of the peaceful death that my loved one envisioned for him or herself. And there is such great comfort in that. Conversely, there is incredible trauma in the consternation of, I don't know whether we should do dialysis. I don't know, you know, I don't know if he wants this or she wants this. And that to me, that's just the tragedy of it when that happens, because it's so avoidable when we simply recognize that at the end of life comes death. And if we're just willing to have a conversation, and ideally to start it when people are either healthy or relatively healthy. Right. Yeah, so I think to me, that's the greatest risk for the trauma.
I think it's important for everyone, right, involved with, so the patient and the caregivers, to understand each other's situation. So,
absolutely.
and I think that would help with the relationship moving each step forward. So that book that you mentioned, that sounds amazing. I think patients should read that.
Yeah, and I would add that those conversations about end of life preferences and plans and is a great intimacy. It is a closeness in your relationship that it is really indescribable. I mean, it is the greatest intimacy I have ever known with another person, is to know exactly what they wanted and on every level, and to be able to support them in that. Is another thing that palliative care is so amazing about is treatment decisions. There is a new chemotherapy coming out about every 2 weeks at this point. And I mean, not necessarily for metastatic breast cancer, but for cancer in general. And I mean, I think by the end, Bob he did not take the 5th one. Okay. They were most of them were oral, and the last one he got it, but he never actually started it. We don't need to go into that, but I would observe how he would make that choice, because doctors make that decision very differently than the rest of us, right? I mean, and so kind of I translated that. That was one of the pages in my journal, was how he would go about making those treatment decisions. You know, what is this for? Is it going to extend my life, or is it just going to comfort, give me less pain? And then, kind of working through that decision. And I did have a palliative care doctor tell me, that's about 95% of palliative care, that page right there, just because it's such a difficult choice, because some of these treatments have, really potentially very difficult side effects. And you're getting into I'm nearing the end, and I want this story to go like this. I want, to be in my bed comfortable, or to be at home, whatever it is.
One more thing about goals of care, and that certainly, Jennifer really touched definitely on a lot of that. And I know at times it could be very challenging to even have this discussion with patients. Quite frankly, some patients don't want to discuss their prognosis, their mortality, what the future might bring. But I'm very persistent, and I still find a way to still engage in that conversation. I often use or ask for experiences with other family members, maybe with a dying mother or father, and usually that still opens a good opportunity, because it's not about them, it's about someone else, but it really helps me elicit what they are. And then I finally then, I asked them, if this happened and it was so traumatic, do you think this might be something that you can, that you can live with, that you could have done for yourself, for example? And so even if I'm not really speaking directly about their own condition, their own mortality, I kind of use that window and talk about maybe a neighbor, a family member, maybe perhaps it could have been a family member who died in the intensive care unit. And oftentimes I'm able to elicit a lot of information that way. And it really helps us to kind of map the future in terms of the goals and the things that we wish to have done or not have done, for example. And, that also, it touches the comment that Marianne was speaking about earlier about the PTSD. When I was a resident, this is where I would probably see the most trauma. Not so much a patient in hospice, but perhaps a patient dying in the ICU, perhaps alone, uncomfortable, with not as much support as they could have had. And so I try to use, other people as the window of opportunity to get them to speak to me about what's important to them, if they don't want to really talk about themselves.
So, Dr. Medina, is nurturing those family relationships between the caregiver and the patient, is that part of what you do? Because it sounds so essential to moving them all forward.
Absolutely. When I have my consultations with patients, one of the things that we really want our families to understand is that cancer, like you mentioned earlier, affects everybody. It not only affects the patient, it really affects the entire family unit, the children, the spouse, or other caregivers. And I tell them, we are all a team. If we really want to do as best we can with your condition, where we are right now, we all need to, to work together to really, map a way for you to have the best outcome, certainly. I mean, if there's no, unity, I guess, in the family unit, potentially there could be many, many problems.
Right.
And I was wondering too, as Jen is talking about this, the process of walking through the death of someone that you love is an incredible opportunity for intimacy. You have the flip side of that, where there are people who are not emotionally equipped to do that.
Right.
And so in a situation where you see that, Dr. Medina, that maybe the family isn't dealing with things very well, or the point that you made earlier where a family member doesn't, or your patient doesn't want family members to know something,
Right.
how does your care change in that particular scenario?
I always ask permission to bridge certain subjects. That's really, really important. It's a sign of respect. Also, if I sense that my patient is not ready to dive into that conversation, I focus on the next priority. And then perhaps I ask them, what can we do, perhaps in the future, or I try to, I guess, evaluate, when would be the next best opportunity. And usually if that doesn't come, I usually use events and transitions as a point to have another goals of care conversation, whether it was a recent hospital stay. It could have been maybe my patient was hospitalized 3 times in the past month. Maybe in the last hospitalization, my patient was intubated. And so these are my transition points where I dive in to engage and have this conversation again, because it brings context. You're not just asking, a question out of the blue. Well, if this happens, what do you want done? It doesn't make any sense. You have to have an event and you have to have context to really have that conversation. And often when that opportunity presents itself, it becomes very easy because now we have context as opposed to when we don't.
Just like we talked about during the estate planning webinar, where it'll trigger conversation about what you want when it's compared to someone else's experience, that most people start to think about that usually when it's a bad experience, right? We talk about the people who have passed away in the ICU in pain without anybody near them. When you see, I don't want that to happen, that often is a great conversation starter. So that's a wonderful example. I want to ask each of you to give one last comment or one last message that you would like everybody to come away with. And then I'm going to ask each of you to give me a word that exemplifies what you have talked about today. So we'll start with one last message while you guys are thinking about your word. And we'll start with Dr. Medina. What would be the one thing that you would like to leave our listeners with as we wrap up today?
I think my takeaway point will be to really take the time to speak to our patients, to ask lots of questions, to really ask what's really bothering them during this, time of their life. How can we support them? How can we help them do the best that they can possibly do? And let them know that there's a lot of support available for many different, circumstances. But definitely listen, ask lots of questions, and assess all the time.
At the end of life comes death. There are no do-overs in end of life. Changed forever, the survivors remain. And talking about it neither hastens nor delays it.
Because you are worth it. You deserve the care that is out there. And I want you to go after it and be that squeaky wheel. And you're not out of line. You are just asking for what you are fully within your rights to ask for as early as possible. And if you need more support, you can go to getpalliativecare.org. You can come to my Facebook page, Advocating for Supportive Care, and you can find other resources as well. But absolutely take the time and the energy to get yourself supportive care.